start the session. I think we're recording now. Thank you very much all for joining this Sunday, 28th of June. Welcome. I've got here with me Dr. Simra, Dr. Zahra, Dr. Lima, who will be conducting this session with me. And as you know, today we're going to be focusing on two key things, AMC Clinical and job prospects. And I'll be talking about the CVs, the interviews, and the job recruitment campaigns, what's happening from that point of view as well. So first of all, let's just do a quick round of introduction. My name is Rizwan. I'm an emergency consultant working here in Australia. And I'll carry on the baton to Dr. Simra and then Dr. Zara and Dr. Lima. Can you please quickly do the introduction so we can start the session?
Good afternoon, everyone. Dr. Simra here. I'm one of the registrar trainee in Western Sydney Network. And apart from that, I'm the career counselor in IMG support group by Emergency Focus.
Excellent. Thank you, Dr. Simra. Dr. Zara, our very old tutor.
Yes, hello everyone. I'm Dr. Zahra and I'm an international medical graduate from Pakistan. Currently, I'm preparing for PESCI and about to start my GP practice. And for the last 3 years, I've been tutoring for AMC exams, and now I'll be joining this batch as a AMC clinical tutor.
Excellent. Thank you very much, Dr. Zara.
Thank
Glad to have you on board. Dr. Lima.
Thank you.
Good afternoon, everyone. My name is Lima Salman. I'm a psychiatric registrar working in Western Sydney. I'm currently joining as a new AMC clinical tutor with Emergency Focus.
Excellent. Glad to have all your positive energy and vibes. Despite the fact that it's on Sunday, I'm really glad that and thankful that you're making time to make allowances. Okay. So look, after the introduction, I'll just give you a layout. We're going to keep this session as tight and specific as possible. The job aspects and the job CV interview and the career recruitment always take more time. So me and Dr. Simra are going to be talking about that later after the AMC clinical, because I think most of you, or at least majority of you, would have passed the AMC MCQ, or maybe some of you may be thinking about the AMC MCQ, but majority I still believe would represent a cohort who have passed their AMC MCQ test, and they would be hoping to register for, AMC Clinical or AMC Clinical Exam and so forth. So what I'll do is I'll get Dr. Zahra to start off with a case of AMC Clinical, and then Dr. Lima will present a case with AMC Clinical so you can have a bit of an idea how the case are conducted and how the cases should be attempted in order for you to pass. Because AMC Clinical, and I'll say that out loud, with the increasing number of doctors coming to Australia, we have seen a trend now that AMC Clinical is almost required exclusively by certain states and certain hospitals. They won't shortlist you if you haven't got AMC Clinical. And if you want to really improve the job prospects, in addition to your clinical experience, AMC Clinical really counts a lot. So that's why we're emphasizing AMC Clinical. Just as you've seen PLAB 1 and PLAB 2, the equation completes to get you into the job market. Same as here with the increasing competition, AMC Clinical is going to make a real difference. So Dr. Zahra, whenever you're ready,
Yes.
I would like you to start.
Thank you, Dr. Swan. So I'll be talking about the AMC clinical exam. I'll give you a little bit of introduction and then we'll be discussing a case in detail. So about the AMC clinical exam itself, you might have a little bit of idea that it's an OSCE exam and there are 16 stations in the exam. Among those 16 stations, 14 stations are marked and 2 stations are pilot. On the day of the exam, you will not know which stations are pilot or unmarked. So it's recommended to do each and every station as if it is marked. So from the 14 stations that are marked, we have to pass 9 stations to pass the exam. This is how the OSCE outside the AMC Clinical Center looks like. This is a picture from the AMC website itself. There's only one center for the AMC Clinical Exam, face-to-face exam, that's in Melbourne. So outside the room, there is a screen which displays the question and you have 2 minutes to read the question. When the bell rings, the question will appear on the screen and after 2 minutes, you will enter the room next to the screen to perform the station and perform your task. As soon as you enter the room, the examiner will be standing on the door. He will greet you, check your card, and this is how the inside will look like. This is just just to give an idea. The examiner will sit behind you. There will be a copy of question inside the room. the screen will be there inside the room and a hard copy on the table, and the patient will be sitting on one side of the table and the examiner will be behind you. So you will be you'll start the history from there, and then so when you enter the room, the examiner will tell you the patient's name. So primarily, because when we start teaching AMC Clinical, we tell the students that how the questions might look like. Because if you have a basic idea of how they're going to test you in different aspects of your clinical practice, you can have a systematic approach towards it, and you can solve it in a better way. So basically, there are five major type of questions that appear in the exam. Obviously, history taking questions that come with a primary complaint. It could be a pediatric, obs, gynae, or medicine question. Then comes that you have to be there. So basically, history taking questions. Then are the mental health questions, a psychiatric patient or a psychosocial assessment, where you have to be very empathic, but also have to have a good control over your history so that you can control the overall case. Then comes the patient education question, where you don't have to take any history. All the information will be given in the question, like a biopsy report, breaking a bad news, or any blood test, and you just need to go inside and counsel the patient regarding the blood test or the biopsy report, or maybe a MRI report. So in this question, there will be no history taking. The fourth type of questions are the physical examination from the examiner questions that are primarily new type of questions. Since last 6 months, they have started to appear, in which there will be no patient inside the room. You go inside the room, you will be given a primary complaint, like for example, a post-operative fever or a postpartum fever, and based on that primary complaint, you just need to ask the physical examination findings. There's no history available, and based on the physical examination findings from the examiner, you have to come up with a diagnosis and explain the reasons for your diagnosis. And the last type of questions are actually the physical examination performance, where you have to perform the physical examination. So obviously, we'll talk about each of these in detail in the course itself, and we will show you how systematically you can solve each of these. But primarily, I'll be talking about the history taking questions today. So in the history taking questions, there are further two types, like 6-minute and 4-minute history. The 6-minute history is a GP clinic setup, where you have to be really thorough with your history and you have to cover maximum differential diagnosis. And then a 4-minute history, which has to be a very focused history, like a ED setting, where you can't be really thorough. You have to keep the patient safe and you have to make a decision very quickly. So the 4-minute history, that will obviously, they are testing different aspects of your clinical practice. So each of these questions will appear for each of the candidates for every day. So we can try a 6-minute history question today, and then when we go through the course, we'll have a layout for each of these type of questions, so you know how to solve them. So let's solve this question. You are working as a general practitioner, and your next patient in your clinic is a 42-year-old female with complaints of dysphagia/swallowing difficulty. The tasks are: take history from the patient. This task should be completed in 6 minutes. So this will be given in the question, that how long you need to take to finish that task, and explain the diagnosis to the patient with reasons. So for this question, whenever the question appears, I always ask my students to, when you're outside, you're reading the question, the 2-minute thinking time, after reading the question, you always think about the differentials, because the more the differentials in 6-minute history, you're more accurate and thorough in the history. So I always have a kind of picture, because when you're standing there, the picture is easy to remember. It pops up in your brain and you think about all the differentials. It's easy to remember. So when we talk about swallowing difficulty, obviously gastrointestinal tract, primarily upper GI, is the main system to think about, like esophagus, oropharynx, and larynx. So among these, esophagus is major. Esophagus is the major to be think about, like esophageal atresia and esophageal cancer. Then we talk about things that can cause dysphagia that are around esophagus, like a lung cancer or a mass in the chest. We can think about cancer of the thyroid that can press over the esophagus. We can think about mouth or oropharyngeal cancers. We can think about connective tissue disorders like scleroderma. And at the end, we can also think about brain and like stroke, Parkinson's disease, myasthenia gravis, and things like that. So when we will have a layout for these questions, obviously we go inside, we start with introduction. So we start like, hello, I'm Dr. Zahra. I'm one of the journal practitioners working here because the GP setting question was there, like you are in a GP setting. It was already provided in the question. How can I help you today? And the name of the patient will be told by the examiner. So the patient will say, hi doctor, I'm just having a difficulty in swallowing. So you add a little bit of reassurance by saying, please don't worry, I'm really happy that you came in. Just let me ask you a few questions to understand the situation better. Just to give them a heads up that now there are a lot of questions coming up and you need to ask them a few questions and to maintain a little bit of rapport. The next part after reassurance is HOPC, a history of presenting complaint, which is dysphagia or swallowing difficulty. So you dive in deeper into the HOPC. You ask about the duration. How long have you been having this swallowing difficulty? Is it continuous or on and off, to know about the frequency? And is if it on and if it is on and off, how often is it happening? Then you talk about the severity, you talk about type of dysphagia, solids or liquids, and then you talk about the location to know whether it is esophagus or throat or a chest mass. After you ask the history of presenting complaints, you ask about associated symptoms like, do you also have any pain while swallowing? Do you also have any vomiting or nausea? Did you ever throw up any blood like hematemesis? And did you ever have any regurgitation or backflow of food into your mouth? Then the next part will be asking the differential diagnosis. And for the differential diagnosis, we always keep the most dangerous first, like cancers, having a high index of suspicion to rule out the most dangerous causes first. And if you don't rule out the red flags, even if you get to the right diagnosis, you will not pass the case. Like for esophageal and gastric cancer, you start by asking any weight loss recently, any loss of appetite, any black stools, any feeling tired lately, any lumps and bumps anywhere in the body. Then about the esophageal stricture, a history of reflux, eosinophilic esophagitis. So still in the esophagus, we're asking all the differentials of esophagus. Then we move on to larynx by asking any hoarseness of voice. Then about the thyroid cancer, like any enlargement in your neck, any weather preference. Then about the lung cancer, that can be a mass that can be pushing on the esophagus. We ask about cough, shortness of breath, any have you ever coughed up blood? Then about scleroderma, that any thickening of skin, nervous system, any weakness in any part of the body, and the psychiatric causes like, do you have any ongoing stress? After we have covered the differential diagnosis, we close the case by asking previous medical and surgical history. Like previous history of GERD could be important, that can cause Barrett esophagus, leading to esophageal atresia. We can ask about stroke. We can ask about any previous surgeries, any medications like NSAIDs, bisphosphonates. These can also cause esophageal atresia. And at the end, social history, including smoking, alcohol is important because they can cause increased risk of cancer. At the end, we ask about family history of cancers, and based on the history, we close the case. So there are two recalls that come with dysphagia. One is esophageal stricture, and the other is with the cancer, depending on the history. And we explain the patient, because the second part is to explain the patient. So look, Jenny, from the history, most likely you're having a condition called as esophageal atresia. So this part has marks, like if you don't say it, you don't pass the case even if you have done a really nice history. So what is esophageal atresia? It's the narrowing of the lower part of your food pipe, and it usually happens in your case because of the long-term reflux that you've been having that can cause inflammation and narrowing there. So we can also draw a picture because there is a paper there, and you can quickly draw a picture to make the patient understand better. And then another task would be differential diagnosis. So you say it, I was also thinking about esophageal cancer, but you don't have any red flags like any weight loss. I was thinking about thyroid cancer, but you don't have any lumps or enlargement of your thyroid gland. I was thinking about lung cancer, but you don't have any cough or sputum. I was thinking about scleroderma, but you don't have any skin thickening. And all these differentials are actually showing off your knowledge to the examiner as well, because you tell him that I was thinking about all these and you're trying to rule out. And similarly, if it comes out to be esophageal cancer, empathy is very important. You need to have a sentence that is strong but empathetic as well. So, Jenny, from the history today, I found out some red flags like weight loss. So, I'm thinking about the possibility of cancer of your food pipe. And take a pause here just for 1 or 2 seconds and give a little bit of reassurance. Please don't worry. I need to run some tests to confirm it. I was also thinking about esophageal atresia, but due to some red flags, I'm more worried about cancer. I was also thinking about thyroid cancer. I was also thinking about lung cancer. And then you mention all the reasons why that could not be the cause. So this is how the scoring happens, and this is important to see it because when you, as you know, that there's no clear cut course by AMC that how to prepare the exam, but when you see how they score you, it's important to prepare on these lines. Like for example, for a swallowing difficulty question, they will score each of these up separately, like approach to the patient and relative is scored separately. Out of 8 you need to get 4 to pass the station. Each one of these is scored separately. If you're good in history, like you're getting 6 in history but 2 in approach to the relative, it's difficult to pass the case. So you have to pass each of these aspects separately. Like history, it should be more than 4. And similarly, all of these. Like similarly, you can see in physical examination cases, choice and technique of examination is important. Even if you are pass in accuracy, you did it accurately, your diagnosis was correct, your approach to the patient was correct, but if your sequence was not correct, you will fail the case. So this is how it happens in the real exam, and that's how we're going to help you to have a good systematic approach in all of these lines to pass the case, not just with the good history, but also having a good approach to the patient and having a proper differential diagnosis. So, if you have any questions, I'll be happy to ask. But first, I think
Yeah.
over to Dr. Rizwan.
Thank you very much, Dr. Zara. That was very enlightening. And I think what I liked about your approach is I'm trying to make references to the real life scenarios. First, I'll talk about the question which has been asked in the chat box is that the people are asking, can we take notes while we're waiting outside the OSCE room? Or can we write in an exam room paper, especially while doing mini mental state examination? What do you think about that?
Outside the examination, when you're standing here, like you're not allowed to even whisper because it's immediate termination of the exam. You're not allowed to whisper, you're not allowed, you have to just read it in your head. So there's no paper, pen, nothing outside. But when you go inside the room, on the table we have a paper and a pen and a copy of your question. So you can write there. So you, what I did with my exam, that I used to write the patient's name there and then, because you tend to forget when you're doing multiple stations. So if it's Jenny, okay, Jenny. And then I used to draw a lot, like to explain the patient that, okay, this is how, this is what's happening to you. So I think drawing and writing really helps, and I did that, and it's good to have that practice.
Perfectly said. I could not have said it better. So, realistically, when I'm working on the floor with the doctors, I know and I've seen that people who have passed AMC clinical, they're much more confident whilst managing the patient in ED, just because they've done a good study material, a study of a
Yeah.
large amount of material, which is actually relevant to emergency medicine practice here in Australia. The second
Yes.
thing, which I completely agree, Dr. Zara, is that sequence is so important. Like when we are actually in real life, you do history, you do examination, and then also from the counseling point of view, after giving the analgesia and then coming to the specific issues, it's just not only from the patient perspective but also for the examiner. When they've got their marking schema, it's so easy to tick off everything in a quick succession. So I completely agree with that. Now, one thing which I often get sort of confused about, and I'll take your points on it, is about the word cancer, because we've just taken a history, and obviously in the history there would be very specific telltale signs that look, this is pointing towards a cancer with a weight loss, with a smoking history, or some sort of blood coming out, especially with the history of difficulty in swallowing. That in itself would point out to a cancer. But do you think it's okay to say cancer when we don't have a histopathological diagnosis or some sort of mass lesion, perhaps?
So previously, what happened was people were using a lot of other terminologies that might sound like a nasty mass or something. But recently, the AMC website has given a handbook, like it's rules or recommendations from examiner which clearly mention that you have to be very specific what you're saying, just to because this is a OSCE and the examiner also needs to understand what you're thinking. A nasty mass or a growth doesn't really so they have primarily mentioned it that don't use the words that are closer or don't sugarcoat the words. You have to say what it is. So previously we were doing the same thing, like we were saying it in a very politer way, like not to just shock the patient or just to be, because we're not sure yet about the diagnosis. But now the AMC has themselves recommended to say the proper diagnosis. And yeah, so we have to say the exact diagnosis, like
Excellent.
esophageal cancer. It's for the exam point of view. They
I
think
agree.
that saying that makes it clearer for the examiner to mark.
Wonderful.
S-
No, that makes perfect sense. So
Yeah.
thank you very much. I believe that we'll move on to Dr. Lima. If you can just stop sharing your
Yep.
uh, the thing, then I think we will be okay. Dr. Lima, when you're ready, we're ready with your cases as well. So whilst Dr. Lima is setting up, these are all very practical points. What Dr. Zahra has said, you need to be very specific because it's not only you talking directly to the patient, but it's also the fact that you are talking and showing it to the examiner so you don't miss out. So
Yep.
not only being organized and systematic, but also it's important to be more specific, showing it to the examiner what's
Yeah.
happening. All
Yes.
right. Looks like I can't see anything, Dr. Lima. I think it's a white screen right
Yeah,
now.
yeah. I'm just about to start the case.
Okay. All right. So Dr. Lima is working as a psychiatry registrar. She's got a case for us. And Dr. Lima, when you're ready, you can start.
Yes. So before I start, thank you, Rizwan, for giving such an opportunity
Oh,
now.
Dr. Lima and I go a long, long way time back. I think
Yeah.
we first met right in the COVID time, right?
Yes, yes.
And
I would have been one of your first students of your
yes,
first sessions. Yeah.
yes, clinical orientation, AMC clinical, and now
Yes.
you're psychiatry registrar, mashallah. That's very good.
Thank
And
you. Thank you.
I like to, when I'm doing the job thing, I like to, create some examples, but I don't want to steal the light from you. So
No,
just carry on.
no,
Please.
no, that's all good. That's all good. So before I start, I want to tell that like I can actually hear the heartbeat of everyone who are planning to sit for AMC Clinical now.
Mhm.
I understand it's a very really tough exam, especially when you come to a new country. We don't know anything and the health system there. So before we go into the cases, I just want to talk a bit about what is AMC Clinical itself. See, all of us are doctors and we have enough knowledge to pass the exam. There are two ways we can do it. Either we learn everything under the moon or we structurize what we learn. So our key aim would be to focus more on how we structurize the exam so that it'll help you to pass the exam in first go. So most of the time, from the past feedback, the amount of effort put in to for the structurization has helped to achieve more past stations. As Thank you, Dr. Sarah, for explaining everything, how the exam and the format of the exams. I just wanted to point out one point from that. So each station or each task is marked as 7. That is like the total score, and we need 4 to pass. So there is a bit of room for error. Even then, like think like in such a way that out of 7 we need to pass 4. So
Yep.
I need to assure you that like structurization is the best way we can achieve it. So I would like to start with one case. I have two cases, so I'll show you how we put a structure to the first case and apply it in the second case. So
Wonderful.
the case goes like Miss Amanda brings her 4-month-old baby to your GP clinic because the baby has been vomiting after feeds for the past 2 days. So the task is, the screen is exactly like this outside the AMC Clinical. The task is take a focus history, perform and describe an appropriate examination. What is the most probable diagnosis and list some differentials, outline the immediate management. So normally either it would be as Sarah told, like it would be diagnosis and differentials or management. Both of them doesn't, three of the tasks come together. Okay, so this will have a 1 minute thinking, 2 minute thinking time, and you can take a 2 minute thinking time here. So mostly we are focusing on, in this 2 minute time, what I do is a differential oriented symptom questions. So I think of maximum differential that can come into my mind of the kid. A kid is vomiting in front of me. What is my thoughts? That's my first task I think about. So they also would have given a growth chart, which on a first go with a panicking thing, it'll be very difficult to analyze. But before I start, I would like to say, whatever examinations or whatever things that they have given to you, just try to sit down and analyze without focusing on the time, which will give a more differentials to our questions and tasks. So in Australian emergency, we approach a patient in two ways. Either they are acutely unwell or they are semi-urgent. So always focus how to deal with an acutely unwell patients, because it takes more time than acutely well patients. So when you go inside, the approach would be like, in your, this should be in your mind always. So introduce yourself, get the consent from the patient, and see whether hemodynamically stable. That's when you look into the monitors and see whether what is the heart rate, blood pressure, respiratory rate, saturation, and temperature. And if this determines whether the patient is acutely well or unwell. So we categorize into unwell or well patient. In this case, we see whether the baby is well or unwell. So if the vitals are stable, the baby is well. We skip all the other tasks and go into task number 8. So we reassure, as Dr. Zero told, and we start taking the history, examination, investigation, and definitive management. So this cut shorts into 1 to 8 and 9. That's what we need to focus. And if the patient is unwell, there are cases where a pregnant lady comes in with eclampsia, and all on a sudden, when you're starting the history, she just collapses like that. So that's when it goes to the tract of unwell patients. So you just call for help, transfer the patient into rhesus cubicle. All this words should be out of your mouth. This is what actually happens in an emergency, in Australian emergency as well. So we call for help, we hook them into the monitor, we continuously monitor them, we establish an IV line, we take some bloods, and we perform the ABCDE assessment and make them stable. These steps are repeated again and again until they get well. So in AMC exams, if you tell like this 2, 3, 4, 5, 6 steps, then automatically the patient is going to be well. They don't want you to repeat all the step again. As you tell all this, the patient automatically go to that pathway of well patient. Then you continue with the history. So introduction, as Dr. Zera told, I don't want to touch a bit more on this one because we have learned how to do introduction already. So I would like to classify the history in pattern of Socrates, which includes of site. Here, the site is not a very important question. So onset, when did it start? And how, is it sudden onset or gradual onset one? So the character, here the character would be focusing more on the vomiters. What is the color of the vomiter, character of the vomiters, any blood mixed in. We'll go more detail into what all questions to be asked. Then radiation, in this case, I would say, is it like more associated factors with it, symptoms with it? Is there any fever? Is it like blood vomiters? Is it like yellow vomiters? Like what are the other associated factors? Like is the baby gaining more weight, losing weight, and have you seen him more floppy, lethargic? What are the associated features with it? What is the timing? Is it like an early warning vomiting? Is it like a late? Is it associated with nausea? So this is very common in all the history taking. The Socrates is like the idea of taking history. So when you go to an AMC exam, the simple tactics are very important when you take history, because that is the one gonna be clicking into your mind first in under a panic situation. So exacerbating factors and severity, how severe are the symptoms. So this is like a picturization of how would will you ask and how we classify the Socrates. So in this case, the more major thing is the onset, characters, associated symptoms, timing, exacerbating, aggravating, and severity. So presenting complaint ways, the major symptom, first symptom explained is vomiting. So what is the onset of, when did the vomiting start? Was it sudden or gradual? The duration, how long it has been occurring for? How many times he vomited a day? And what is the volume of the vomit? Is it like large vomiters or a small spit ups? What is the character? Is it milk, just milk coming out? It's just bile, green vomit, any blood, any projectile nature of the vomiting? What are the relation with the feeds? Does he immediately vomit after feeding or during the feeds, several hours after feeding? And progression, is it getting worse, better, or unchanged? So we learned about Socrates, we learned about how we take the history. Then next step should be previous episodes or previous diagnosis. So this is very commonly used in all the case, just not only the Pete's case. This is also a structurization of any similar episode happen in the past. When it start, how often do they occur, how long each episode lasts, what are the triggering factors, are there any increase in frequency or duration, what do you do to relieve them, any effect on your life, like a personal work. This is a general one. You don't have to ask that particular questions in the kid. If previously diagnosed with any issues in the past, like if has the kid been ever diagnosed with any issue in the past, or if it's like any treatment on board, what are the compliance of the treatment, and what who all are following that. When you come to Australia, that is another thing you need to keep in mind, is like it's not like we can go to all the doctors every time. A specialist will be following up a kid from the beginning, so there will be records of follow-ups that's particularly mentioned in their record. So that's very important. You ask which specialist you are known to, and what are the treatments you are getting, and what all things, when is your appointment and when is your next appointment. So specific to pediatrics is like sick child questions, whether the kid is drowsy, active, irritable, feeding difficulties, any reduction in urine output, or any problem with passing urine or stools. The other classic history we put is like Bynes history. So we learned about Socrates. The next thing is Bynes. Bynes gives a birth history, immunization history, nutrition and development history. Birth history wise, what is when the baby was born? Was it a term baby or a preterm baby? What is the mode of delivery? Was it like a normal vaginal section or a C-section or an instrumentation done or not? What is the birth weight or Apgar scores in a kid? What is the neonatal complications associated with the delivery and after delivery? What are the maternal pregnancy issues? Whether the mom had any diabetes or any infections or any preeclampsia while she was pregnant. Immunizations, vaccines up to date or not, according to the Australian immunization schedule, and any adverse reaction to any of the vaccines. Nutrition wise, we already covered a bit of it, like whether they are formula fed or they are breastfed. Weaning and whether they are trying to be weaned off into solids, current diet and quality and quantity, and feeding difficulties, weight gain and concerns. Development ways, whether the milestones are up to date, any regression of skills or school performance. And this is a general one as well. We use this for all of the pediatric one. In this case, particularly the red flags or sick child questions should be, what are the number of nappies, whether it's fever, number of nappies, any dry mouth, any crying without tears, any sunken eyes, any sunken fontanelle. The systemic symptoms associated along with this would be any fever, lethargy, excessive sleepiness, irritability, or seizures associated. The nutrition wise, as I've told before, breastfed, formula fed, feeding well, recent feed changes, any overfeeding, any solid introduced here. So birth history here would be the same as we explained before. What age was the gestation? Whether it was a vaginal delivery or C-section, birth weight, neonatal complications, or any NICU admissions. So history taken would be Socrates, and previous episodes we asked a bit about sick baby questions and the bind history. And next one would be a system review. That is part of the physical examination. So review of system, definitely vomiting is part of a gastrointestinal system. So the main focus would be the gastrointestinal system here. This also is a general slide which shows what all things should be asked in particular to the Socratic history, on top of the Socratic history, from particular systems. So here the gastrointestinal question would be any diarrhea, any constipation, any abdominal distension or bloating noted by Mo. Is there any blood in stools, or is there any failure to pass stools? So this is also a general history a pattern of not only in kids but also in adults. It's SATMA. That's also another acronym we use to as part of like a general history. S includes social history, any parental smoking, sick contacts, daycare. When it comes to adult, we classify this as adult SATMA, where it won't be parental smoking. It would be more of like any smoking, alcohol, drugs used and things. So we modify, this is how I was talking about the structurization. We modify this according to adult pediatric group separately and geriatric group separately as well. Any allergies associated with that, any drug allergy, any food or environmental allergies, any type of reactions has ever been observed in the kid. Any drugs here, the medications in the kids, the major medications associated, most of the, since Australia is a multicultural country, there are a lot of people who use traditional medicines from different countries. So particularly that focus is done on this side. Dose frequency, compliance, any recent change in medication, any medical history, any allergies in the kid, and travel and contact with sick people. So this is different in adults and different in children as well. So sick contact in children would be from daycare, from adults will be from the workplace. In this case, the medication would be any medications, vitamin supplements, family history of any gastrointestinal disorders, any food allergies or metabolic disorders, social history of any sick contacts, daycare attendance, smoking exposure. So that gives an idea of SATMA. Then next would be coming to the examination part of it. Examination has general examination and system examination as well. So general examination would be PICCLS. That's the term I would like to use. So PICCL includes pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema, and dehydration signs. And then we look for the vital sign and growth assessment. So in Australian ED, when a sick child is brought into hospital, they are transferred to resus cubicle and hooked to the first thing they do is before the doctors come, the nurses will hook them to the monitors. So that's when all the vitals come up, and a growth assessment, which is also done in a stable child. So in this case, generally we look whether the child is happy or like he is smiling at you, alert, or he's irritable, lethargic, crying, toxic looking. Then observe the color, breathing efforts, and hydration. So the vital signs would be asked the examiner for, like temperature, heart rate, respiratory rate, blood pressure, and oxygen saturation. And also the growth chart. The growth chart would already, I have already shown you the growth chart with a normal value in the growth chart. So next would be a system review. System review would be, particularly in this case, would be the gastrointestinal system. The gastrointestinal system questions would be, first start with the hydration assessment. So in mild to moderate dehydration, look for dry mucous membrane, reduced tears, sunken eyes, reduced urine output, and severe dehydration would say like sunken fontanelle, delayed capillary refill time, poor skin turgor, tachycardia, and hypotension. So abdominal examination, all the examination goes as inspection, palpation, auscultation, and specific signs looked in. So inspection would be distension, visible peristalsis seen or not. Palpation would be tenderness and any organomegaly. Specifically look for any olive-shaped mass in the right upper abdomen. In AMC, there are particular pitfalls which are very exam friendly. So in this case, one of the exam friendly tip would be pyloric stenosis. So it straight away a human person who is marking as an examiner, this gives an additional point to put an additional score for you. So there are a specific pitfall in specific cases, which we'll come across when we come detail to the cases. And auscultation, bowel sounds present or not. So this also should have another system exam, neurological examination. So two candidates who goes in who has done a structurization would definitely go for a neurological examination, or along with the abdominal examination, which is another plus point when it comes from examination point of view. That's why it is very important to structurize what you're looking for. So when you think about the system examination, the two system involved will be abdominal system and gastrointestinal system and neurological system. So the diagnosis and differentials would be GERD is the major one. Any happy child coming in with vomiting with normal growth charts, which mostly tend to be a gastrointestinal reflux, which is very common in kids, small volume regurgitation, and if the infant is happy and thriving. The other differentials include gastroenteritis, overfeeding, which is very common in new parents. The other ones would be hypertrophic pyloric stenosis, intestinal obstruction, sepsis, raised intracranial pressure, cow milk protein allergy, and urinary tract infection. So this should be put in such a way as Dr. Zera explained in a very polite way. So, hi, Amanda. So most probably we think he has or he would have would be gastrointestinal reflux. So the question task slide was mainly on focusing on management. So if you have like any exam task telling like say the diagnosis and management, concentrate mostly on the reflex part of it. And you can mention as the other thing would be overfeeding or any other surgical complications associated with it, which is less likely. So management wise, the most hi Amanda, the most important thing to do is every time after first feeding, he need his head raised up 30 degree and kept him 30 degree head raise for some time, and give a small frequent feeds. And if this is not working, we can add a thickened feeds or thickness to the feed. And most of the time the kid get better by this small methods. And if this is still going on, I would like to see you in 2 weeks time, where I can think about adding some drugs which would help to ease that vomiting, which would be Gaviscon, very commonly used, available over the counter. And you can put half teaspoon to 120 ml of formula milk. Then you can make into and give it as a thickener. And if you do not understand, or if you want, I can jot it down or I can write it down, so, which is easily available over the counter. So every time you explain a management, it is very important you mention the red flag. It's same as like anyone who goes from emergency. You tell like if you have like leg pain, if the pain is getting worse, you come back, right? So similarly, you tell to the mom that if the baby is not getting better, if he's getting more lethargic, drowsy, any blood in the vomiters, please come back. Safety netting is very important, which should be done very politely, and they should have like a warning sign noted or jotted down in a paper. So I think like that is the first one. It took some time. So I would like to show you how we use this kind of structurization in a second case. So the second case comes as a 30-year-old female patient, Susan, came to your GP with a headache. She has been suffering from that headache for 2 years ago. 2 years ago, she tried Panadol for the headache, but sometimes it didn't help. Now she's seeking help from you. She's having a blood pressure of 180 on 120 on 80 millimeters of mercury and heart rate of 84 per minute. So the task is to take a relevant history and explain your diagnosis and differentials. This is as Dr. Sarah told. This would be a 6-minute history along with diagnosis and differentials. So same thing, we are trying to initially focus on whether the patient is acutely unwell or well. So we goes into the room, introduce ourselves, get the consent, and ask for the vitals. I would like to make sure that you don't have any pain now, I'm happy to give you some pain medications if you are in pain before we start. So every time a pain is addressed, it's always good to offer analgesia, like in a real setting. So we make sure that like the patient is talking and the vitals are okay. So we skip all this and come to the 8 part of it. Sorry, 8 and 9 part of it. That is reassurance, and also we start with our history. So history goes in the same way. Socrates, just keep in mind, like we are asking for the Socrates. So it goes into the site of the pain. Where did the pain start? Where is your pain? Is in the frontal, temporal, occipital, unilateral, bilateral? Where is the pain? So onset. So we ask about whether it's sudden onset or gradual onset. So I don't want to go in detail about how we use all this Socrates in this one. If it's onset, we ask about where did it start, how did it start, is it sudden and onset, and character was what is the character of the pain? Is it a dull, aching pain, sharp, throbbing pain, or it's a burning or a cramping pain? Is the pain coming into your neck, or is the pain coming into your eyes, or like is the pain causing stuffiness in your nose? So the radiation. So the associated symptoms wise is you have an associated nausea, vomiting, fever, headache, dizziness, or breathlessness. So this helps you to go in detail to the symptom. So how do we address a symptom? So timing wise, is it the first thing that you wake up with, or is it like gradually coming over the day, or like by the end of the day you're having severe headache or not? So what all things exacerbate in the sense like you go into the cold weather, is it making you worse? So every time you ask, AMC exam is a particular exam where unless you don't ask, they don't give you the symptom. So that's why the structure is very important, that you ask. If you ask about is there anything exacerbating the headache, so they just give it. Until you don't ask that word, they don't give it, which might lead you in a wrong way during the exam. And the severity on a scale of 1 to 10, how severe. So this helps you to take the symptom history, that is detail of the symptom. And also I think you remember Dr. Zera was mentioning about the differential based history. So in this case, this is what she mentioned about the differential based history. So migraine will be a throbbing or a pulsating headache. So we asked about the character of the headache already. And the tension headache would be a tight band. So you can ask like, do you feel like a tight band around your head always? So in that way, it makes clear to the examiner who is examining us that like, yes, she is covering the topic of that tension headache. So even if when you miss during the differential, there is some evidence that you have covered the same thing, or you are thinking about the same thing in the history. So that's what I was mentioning in the first place. When you see the task outside the AMC room, it's always first thing that should be coming to your mind should be the differentials that we can mention for that. Or like the pain is sharp or throbbing pain. Does it spread anyway, or what is the impact of on your life with this headache? How long each episode lasts for, and how frequent is it? Worse with light, noise, and activity, and relief by rest or medication. So we all were also covered the same thing in the Socrates as well: associated factors and relieving factors. So in this case, the features of migraine would be nausea, vomiting, phonophobia, and aura. So you can ask about all the associated symptoms. So the red flag questions here would same as in sick child question. Here it would be the red flag questions: fever, neck stiffness, sudden worse of the headache, in like thunderclap headaches. So these points, when you talk about when particularly tell about like, does it feel like the worst headache of your, how will you mention this as like the worst headache of your life? Then if the patient say yes, so one of your differentials would be subarachnoid hemorrhage. So any neurological deficit associated with it, any morning headache or vomiting, any seizures or neck pains associated with it. So same as our general slide I've told you in the previous one, we are applying the same one here as well. So how did it start? Any triggering factors, how long it is there, and is it increasing in frequency, and the relieving symptoms and effect on life, previously diagnosed. So this is, as I've told in before one, very important in Australia, that have you ever been known to any specialist? Have you ever been diagnosed with anything? Are you taking any medications for it? Or if the medications, have you stopped it? Or like, are you waiting for an appointment with a specialist soon? The impact of the life, past history, same we mentioned, similar headache before, any head injuries or any chronic illnesses. What are the triggering symptoms? Any stress, menstrual history, if it's a female, any sleep deprivation, any caffeine withdrawal, how many coffees do you drink a day? Sometimes a certain food associated can also point towards migraine. So SADMA history, which is, this is more adult focused SADMA. You can ask like, where is the problem of the condition, current symptom severity, progress of the illness, and this particularly also includes social history, where you ask smoking, drugs and alcohol associated with it, any allergies, any drugs, particularly any over-the-counter preferred, any herbal medications, any dose and frequency. If they are taking any drugs, they particularly dose of the drug, how often do you take it, or is it a regular medication or like a once in a while taken medication? Any medical histories, it's like any chronic illness like asthma, diabetes, hypertension, or anything that you take medications for, any allergies associated with that as well. The other thing is travel and contact with any sick people, same as we've mentioned before.
Okay, I think in the interest of the time, Dr. Lima, we'll just try end it now.
Yeah.
And we'll basically just touch base on some question, but I like the way that you've simplified the entire approach
Yeah.
and keep it relevant. And I particularly agree with the fact that there's certain telltale questions which would point out towards the diagnosis. And by asking those specific questions, you actually make it much easier for yourself and the examiner to mark the differential, because you don't get marks up until obviously you ask that specific question related to migraine or cluster or tension headache. And it's a very important scenario. It gets repeatedly asked in various different formats, like a cluster headache or migraine, or something which has got to do with the space occupying lesions. Now, some of the questions which get asked whilst you were preparing that, can we use medical jargon while talking to the patient? I believe that medical jargon should never be used when talking to the patient. When you're talking to the examiner or explaining to the medical student or doctor, yes. But what do you feel? Very quickly, Dr. Lima.
Yes, so we are not supposed to use the jargon itself unless we are not explaining what it is. So, for example, if the question goes like diagnosis and differential, so I would put it in such a way that, so what I think is like a migraine. So most of the people know what is migraine. So simple medical jargons like migraine and things are acceptable. But if you tell about like the other thing, I would be thinking could be a subarachnoid hemorrhage. No, it's not acceptable. So that's why I put it as like a surgical complications associated with it. So with the limitation of time, if you are comfortable enough to explain what is a subarachnoid hemorrhage, that is fine. Otherwise, it should be put as a very simple. I still tell that you shouldn't use much bigger medical jargon. But if you have a particular diagnosis in mind, so this case comes with thunderclap headache and it is subarachnoid hemorrhage, you need to explain that. You think like this is called subarachnoid hemorrhage, and you should explain in one sentence.
Yes. Using your own stethoscope or not? Are you allowed to bring your own instruments or not? Dr. Zara.
So you are allowed to bring stethoscope if you like to use your own, but if you're not, if you don't bring it, it's available in the room as well. So you're not supposed to bring it, but you can if you want to. Just the stethoscope.
The other question is that with the pediatric patient, would they be using the mannequin or a child doll, or they would be bringing in a real patient? I think most likely the mannequin.
It's always the parent for the history. Parents know the history and PFE from the examiner. There's only one case with neonatal examination where there is mannequin. That's it.
Wonderful. Something about the management. How do you cover the management aspect, Dr. Lima? That if you talk about the specific management of migraine, how would you address that general management, specific management? And I think follow-up care would be my advice, so that you differentiate and give that, template rather than, giving like a ballpark. What do you think?
Yeah, so obviously, as I've told in the first part, it should be the general thing that you can do at home. Migraine will be just avoid all the photophobic things, the triggers and things. And the specific would be, I'll classify it as a drug management and then specialist referrals if it's like recurring and follow-ups. So most of the time in GPs, there is a general practice in Australia that you give some medication and you see them in 2 weeks. So that is like the follow-ups.
Okay. Now the questions will keep on coming, but we'll move on swiftly. Thank you very much, Lima. I'll now talk about the job situation, because I think with AMC Clinical, the next thing which makes sense is the situation with the job, because obviously, as you know, that you don't need to pass AMC Clinical. You can apply for jobs being passed in AMC MCQ. Obviously, Clinical not only makes you relevant, but more experience when they're recruiting you or interviewing you. And as I said, that whenever I come across a doctor who has passed the AMC Clinical, their performance seems to be much more better. Also, the timeline is shortened, so you get onto the training program, whether this psychiatry training program or GP training program, emergency surgical, whatever it is. So there are definite benefits from AMC Clinical. Now, I'll keep it very simple in terms of job, because I think we do talk about jobs in various formats, and I think I'm trying to highlight the same point over and over again. But I think the questions may bring out the more specific and pertinent issues. So I'm going to be talking about the most common questions which I get asked are, what are my chances? And if my chances are good or bad, how long will it take? Then there are many questions about the component authority pathway. I have GMC registration with PLAB. What are my chances? How can I improve my chances? That's the other thing. And what about the CV interview? And what are my successful chances in various recruitment campaign? So look, let me start off by a story, because I like telling stories. Last Friday, I was working with a doctor who came up to me at my work in emergency department. She said, "Dr. Rizwan, do you remember me?" And I obviously, there's many doctors who I tend not to have photographic memory. I cannot possibly have a photographic memory. But she said, did your AMC MCQ, AMC Clinical, and then did the clinical observation. And now I'm working here in Wollongong Hospital as an accredited trainee in emergency medicine. And, I need some more specific career guidance in terms of how to join the emergency medicine training program. And I thought, is it beautiful to hear that successful story play out in such a manner? The doctor who has actually gone through the motion, through the hardships, and now it's really happened for her. She even passed the AMC Clinical. She's got a job. She's got the whole future in front of her, and I think things would be simplified. So we booked in a meeting for her to come over to me and do a specific career guidance for her. But the point of mentioning this story was that if that doctor can do the specific steps of all the exams, of all the requirements, and find the job, then I think this is directly relevant to the chances. What are your chances? It's a question more specifically asked to you. I can say to you, your chances are chances very tough. The job market is very competitive, and you'll completely lose all your fuel. You'll become tired immediately, mentally exhausted. Oh, Dr. Rizwan said that there are no chances, the job market is very competitive. And then you'll see some of the other doctors who are getting jobs right, left, and center. So I would like to say, and on record, your chances are very good, provided you believe that your chances are good. And I think that's a fact. You've got many doctors here who are trainees. And if I'm an IMG who's come from Karachi and been able to work as a consultant here, I think your chances are still good. Yes, it's not as chaotic and, desperate or disappointing as the UK, not as yet. I think that's when the chances are relevant. But here in Australia right now, we've not come to that situation. Now, the second question is, so chances wise, I'd say stay optimistic, but you need to do specific things. Now, the second question is, how long will it take? There is no time as such. We've seen, and Dr. Simra would be able to highlight, we've seen many doctors getting job as soon as 3 months, and sometimes they take as long as 6 months or up to 18 months. They're very individual issues. Some may not have recency, some may not have passed the AMC clinical, which is important because they've got a large career gap. Some may not have performed very well during the interview, or they may not even be applying for jobs as they are meant to be applying for jobs. So I think this length of getting a job is very personalized again. You need to go through the motion of passing the exams, making sure that everything is in perfect order. And as you know, right now, we're going through the first round of recruitment campaigns. Queensland and Western Australia campaigns just sort of closed. And now the New South Wales and Victoria would be coming in and opening up shortly. So obviously going through the experience of applying for these jobs, if you are shortlisted, experience of doing an interview would improve your chances, even if you're not able to get a job for the next round, which it's not an official round, but the next chances when there are unfilled vacancies coming September and October time. So I think that's where I see many of the fresh and young doctors getting their first break. So it is very pertinent that you are able to spend the time and the energy in this very first few steps of getting the job, eventually leading to that final situation, which is going to be happening in September, October, November, December. The other thing is about the competent authority pathway. The doctors who do not qualify and they are very disappointment. So this is all of you who are here. You have done PLAB 1 and PLAB 2, and you are GMC registered. So what? Who does give a, nobody gives a toss if you've done a PLAB 1 and PLAB 2 and you're not been able to prioritize. Come on. This is not this is your problem. If you've done PLAB 1 and PLAB 2, if you've not been able to get a job, it's your problem. The question now is, what can you do? You're not getting any exemptions if you don't have UK experience. Even if you've done the membership exams, even if you've done clinical observations, no, you don't have any chance. You have to do AMC Part 1. So asking me repeatedly this question that, oh, I've done PLAB, I've got GMC registration, what are my chances, or what can I do? Well, do AMC 1 exam. If you have got a good CV in terms of experience, you will be prioritized based on, because your PLAB is not relevant to the Australian job market. Full stop. Your AMC is your clinical experiences. So when you come to the Australian job market, passing AMC Part 1 is important and your clinical experience is important because you'll be treated exactly as any person who's passed the AMC. Now, if you've done clinical observations in UK hospital, well and good. Now, yes, you don't have to do AMC clinical exam if you've done PLAB 1 and 2. That's a known fact. So don't ask me these questions repeatedly that do I have to do AMC Part 2? Go and spend some time on APRA website and read up these. As of right now, if you've done PLAB, you don't have to do the AMC Part 2. That's it. So I can understand the frustration, what's happened in the UK. In fact, the situation has gone from bad to worse. I was looking at some of the videos that none of the doctors from PLAB were able to get shortlisted for a GP training program. The medical IMT recruitment, which happened, was because the doctors were pre-shortlisted before the prioritization bill came in. So situation is quite bad. Right now, if you want to dedicate yourself as an Australian, all you could do is hope and put all your efforts in before it's too late for you. And it will be too late at some point. In next 2 years, this market will be no different from the UK market. I'm not sure if there'll be a formal official prioritization bill because we haven't seen that happening. But yes, there will be some form of prioritization here, which is already in place. Now, let's talk about the other question is what can you really do to improve your chances? And I always say that, look, clinical experience is the main thing. If you're not working, your chances of getting a shortlisting for an interview are quite minimal. If you have got a career gap, do the recency, spend time in emergency medicine, acute medicine, pediatrics, and obs and gynae. Anything that you're applying for recruitment repping, you need to replicate that. You need to mirror that. Whatever job you're applying, you need to mirror that job so that you assure the confidence of an employer that, look, fine, this doctor has had a very long career gap, but at least now she or he has worked in those specific things which we're going to be offering as a part of our rotation. So if you do that, definitely you've got a very good chance. That really indirectly improves your job chances. And that's what we've seen play out for doctors who have got more than 13 years of gap. So this is factual. This is not me making up some story. This is factual. So your career gap does not make a difference as long as you've taken the steps of overcoming that gap. Now, somebody would ask me a question, oh, I've done masters, I've done clinical observation. You know the answer, guys. It does not mean jack. Your clinical observation is not in lieu of your clinical experience. Your master is nothing for when it comes to the job market. So please don't waste your time asking these silly questions. Clinical experience is only clinical experience, meaning you're working in a hospital setting and you're seeing patients and you're investigating them and you're managing them under supervision. That's what clinical experience is. You don't do that in clinical observation. You don't do that in masters. So please don't ask these silly questions. Now, the other thing is that how much of the other things are relevant in terms of courses and in terms of CPD activities and audit and research. Brilliant. Now you're really talking about some practical aspects. In addition to the core clinical experience, courses matter a lot. You need to be recent in your courses. In addition to your clinical experience, if you've done an audit, wonderful. You're standing yourself out. You're really displaying those positive traits of standing yourself out. The importance of clinical experience plus the courses, the observation, and the audit and research becomes magnified. So if 10 doctors are shortlisted for an interview, and of which all of them have got clinical experience, which is relevant, they will look at the doctor who has got the most clinical experience, then who has done the courses which are relevant and clinical observation, just as the UK candidates were spending time and money and efforts getting clinical observation. I think that's going to be the norm as the things move on. So it it is important for that matter. Okay. No, medical school grade do not matter. Come on, where have you heard about medical school grade matters? These are silly questions. Stop asking silly questions. You're undermining your own performance here. Have you ever heard about someone doing USMLE or plus? I did one supply in year year two medical student. Does it matter? It does not matter. Your medical school grades don't matter. So you can fail and flunk as much as you like. Okay. Um, and yeah, what matters is your clinical experience and the things that I've talked about in terms of courses, clinical observations, audit and research. Obviously, it brings it up. And plus, the most important thing is the discipline of job application. I am doing CV-led service. And trust me, I cannot tell you how appalling the CVs are. I have to literally spend 5 minutes on the first page to understand, are they even working? Or what have they done? If your CV is like a jigsaw puzzle, trust me, guys, you could have been some hotshot of a doctor, but you're not going to get shortlisted. If your CV is not in order, your first page in particular, I've seen duplication like name, email, full addresses, picture, profiles. You don't need all of that. You just need your name, city, country, email address. I won't say you don't even need phone number. How many of people get, okay, fine, put in a phone number. But if you're overseas, they're not going to call you. They're simply going to send you an email. The other thing which matters is just write AMC1 or MCQ pass or AMC clinical pass. You don't have to elaborate in complete AMC, Australian Medical Council, Australian standards, all that kind of detailed information. Nobody cares. It's just a licensing exam, which is more of a requirement than a degree or a qualification. You're putting your AMC as if you've achieved a PubMed 85 citation article. No, 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 no. It's just an AMC exam. It's a requirement. Just put it there and move on. Okay. And then the other thing is that once you, yes, a single line for AMC, eligible for APRA registration. If you're working in Pakistan, India, Bangladesh, or whatever country, put down the registration details from their point of view. And one of the most important thing is put your current job if you're working. This is very important. So you need to put down your first job. Currently, I'm working as an emergency medicine resident or gynecology resident or whatever resident kind of working you are. Describe the hospital, make their life easy. Describe the job that you're doing, how many consultants are there, how many registrar residents are there. Give them an idea, a picture. You can't draw a picture there or share the picture, but give them a worded idea of what you're doing. So this is very important that you give this complete introduction. I'm working in Civil Hospital Karachi, which is one of the largest tertiary level teaching hospital in Karachi, serving a population of, I don't know, 25 million people, something like that. And I work in the busiest emergency department, which has got an annual presentation of, say, 80,000 patients per annum. And my job is specifically taking history, examining the patient, and discussing the case with my seniors. Nothing too fancy, just keep it basic and simple. Now they immediately get it. You're applying for a job. And the role that you're doing right now in Karachi Civil Hospital is exactly what the job you're applying for. You're reflecting on what the job description is asking you. Okay. So take a little bit of time and effort in understanding the job description. Take a time and effort of trying to then look at your CV and experience to match that job description. How tough could it be? Okay. So, uh, and please, there's lots of stupid questions and silly questions coming on. Stop asking me that. like AMC doctor, AMC, can you they apply for recruitment campaign? You're more than welcome not to apply. All right. You don't have to. But trust me, you need to give yourself the best possible chance. Apply for everything. You go ballistics right now. You don't have to disadvantage yourself. Oh, you cannot apply. You won't get a job. Oh, the competition is too tough. Guys, come on. It's a free process and a free world. Apply for each and every job that you qualify, even if it doesn't make a difference. The process and discipline matters a lot. And that's what you need to do. And asking the question, if I say something, it does not really matter. At the end of the day, if you're getting shortlisted, if you're smart enough to do the interview, like look at Dr. Zara. She speaks so well. Trust me, honestly, if there's a job right now in my emergency department, I'd put a word for her. She's organized in her thought,
Thank you, doctor.
structured. She is like everything what an ideal doctor I'd like to work with as a junior doctor.
That's
And
a great compliment. Thank you. Made
see,
my day.
and this is what we like to see, honestly. Now, the other thing is I'd like to talk about is in terms of format. People say, oh, there's an opera format, there's a Queensland format, whatever format it is, it's just the headings. It does not mean that you need to boxify it or, go ditto like that. Just keep it to the basics. Make sure it's not more than 4 pages, including the last page for references. And as I said, first page must have no duplication, clear information which is specific to the job, and as I said, current job in terms of which hospital department, staffing, and your role matching that of a job description. As simple as that. Keep it condensed and keep it relevant. You don't need to write like half a page of job description and bullet points. Just keep it very condensed. You don't need to go overboard on that. If you've done audit, if you've done research, if you've done clinical observation, yes, these are something which are really going to stand you out. Put them on a page number one in your opening personal statement, not more than 3 or 4 lines. Now let's come and talk about a little bit about the interview where people really are able to spin off. And yes, you can do an AI CV if you want to do a CV, but try not to totally depend on AI. Okay, because if you do AI CV, I can really tell you if it's an AI CV in a matter of 5 seconds. It's got no soul. It's like, an electric car, which hasn't got the, it hasn't got that feeling of the engine or combustion engine, what they say. So you need to really put your personalized experiences, the personalized, as I said, that, the AI would know what Civil Hospital Karachi would look like. You would not have ever put that information unless and until you've listened to that information I've just told you. So you need to personalize that CV. When it comes to job, they're hiring you. They're not hiring your CV, that if you write down all these things on the CV, this CV looks so good. They're hiring a person behind the CV. And if you're able to tell me your story in a very good way, you're immediately employable. But if you're creating this generic, a very bland and very soulless CV, nobody wants to hire you because that would be just pretty much everyone. Anyway, brings me down to the question of an interview. Interview is all about personalization. 98% is personalization. How you describe in a very structured format about what you would do in a specific job or situation, be it a clinical scenario or be it a specific governance issue, or how you are the best fit for the job that you're interviewing for. If you're not passionate, if you're bland, if you're just reading out because you've prepared, somebody shared the question, trust me, might as well not attend the interview. You need to create something unique. You're applying for an Australian job market, which is getting slowly and gradually more competitive. You'll be getting high, you'll be one of the highest paid doctors in the world. Nobody's going to put in a platter. Okay, you need to look into yourself. Okay, and trust me, you need to really shake your soul and come out with a very personalized. And if you can't do that, give me an opportunity to invoke and shake up that soul. I will definitely shake some of the souls. Okay, I would love to do that. But if you don't want to do that, then keep applying for jobs. And that's exactly what happens for doctors who are able to bring that personalization experience. 3 months, 6 months, max 12 months. And the doctors who are just average, generic, even 18 months are not enough. So the key is with your own self. If you are applying for recruitment campaigns, try create something different about you. You may have done something which is very important to you. Okay. And stop asking me this question, what are my chances? The chances reside with yourself. If you're doing everything top notch, top quality, your chances are high, better than everything else. You're competing amongst yourself because jobs are there. All right. They are not able to fill all the jobs with Australian doctors. Simple as that. That's a hard fact. APRA has got those numbers 500, sorry, 5,000, 6,000 doctors getting new registrations every year. Those are factual numbers. It's only amongst yourself if you're able to differentiate from Zara. Maybe you speak better than Zara. Maybe you speak better than Simra. Maybe you speak better than any one of us. You are able to create a very personalized experience, and that's what's required. And that's what's going to matter at all. Okay, so I'll get Dr. Simra to talk about the more specific and less pertinent issue which I've discussed, but I hope that that has given you a little bit of shake up call, because I do get these repeat themes of questions which I think they're all in good intention, but but I think you're trying to ask me questions which nobody has got any answers, because the answers reside with you. If you are in clinical depression or if you are feeling low about yourself, trust me, it's only you who's going to come out of it. Yes, we can mentor you and guide you, but you have to follow those very specific motions and step. And there is a way about it. And we often talk about those ways in a very specific and very clear manner. And Dr. Simra will tell you some of those things and share some of the examples. Dr. Simra.
Hello, good afternoon, everyone. Thank you, Dr. Rizwan. I think you have spoke majority of the things that are really important to discuss when it comes to campaigns, when it comes to shortlisting. And thank you for highlighting about competent authority pathway as well, because that is also another area that we need to think about. Because if I talk about the category, I will make it brief, because I guess we have a lot of talk about it before as well. If I talk about the categories over here, when it comes to shortlisting in Australia, we need to always look the campaigns, the shortlisting from a bigger picture. It's not about IMGs, it's about the doctors, whether it's a local graduate in Australia, coming from other networks, from competent, it's up for everyone. So we need to divide the selection process through a category pool. I always talk to the students who are looking for their first job in Australia that if you are strategic, if you know the facts, and if you're organized according to that, you will be less frustrated, and you will be having a good time management and organization related to that. And that can definitely give you a better outcome as well. So talk about the first thing. Hello?
Yes, I think you're cutting out, Dr. Simra. Yes. I think Dr. Simra's connection is lagging a little bit. Um, let's give.
Hello? Yeah.
Can you hear me, Dr. Simra? Yes, you can speak. I can see you, but I think your connection is lagging a little bit.
I do hear you.
Mhm.
Let me.
If your connection is lagging a little bit, you can turn off your video and speak. All right. As Dr. Simra is coming, I'll take it from there. So what Dr. Simra was talking about is based on her very specific experience of doctors that we work with who have been able to do the job. And I think one of the things which Dr. Simra always shares with me is the doctors who are proactive. So we do, as you know, a complete job mentorship program, and we see good outcomes in the doctors who are actually bothering us. I want you to bother us. I want you to say, I want to. So the word is personalization. If you want to create a personalization aspect to your personality, bother me, bother Simra. Because doctors who bother, we make them their CVs. And if their CVs are further modified by them and then they come back to, look, this is what I've done to the CV. Do you think it's got a good chance? Those are the doctors who make a real difference in terms of getting the jobs early. The doctor that I was working on Friday, she was able to create that kind of experience as well. Dr. Simra, you there? Can you speak now?
Yes, I'm not sure. I'm so sorry. I'm overseas right now. The connection is a bit up and down from here. I'm so sorry for that.
Yeah.
So I've been attending the session from last more than an hour, but it just come. Yes. So if you all hear me well now, I can continue the thing now as well. So if we talk about the category over here, that is very important when it comes to shortlisting. So we need to divide the categories from A to D. A will be the first, the local graduates, because we need to remember that we are international medical graduates. We are not the local graduates. If you are in Pakistan, Bangladesh, and India, you know the quota system, how the selection process works, and you are the prioritization category in your country when it comes to shortlisting about residency program. And you also know that when you are applying for a residency program in your country, how competitive it is despite you are a local graduate. So that is the first thing you need to bring in your mind. Second thing is that, yes, second thing will be coming to the competent authority pathway. Yes, they do have space, but now the things are getting forward. So we are looking for other doctors. Okay, let's go to the countries whose system match somehow with the Australian healthcare system, that is NHS, Ireland. So let's prioritize the second category that is coming through competent authority pathway. If I talk about the third category, yes, now comes the international medical graduates. I'm really thankful to Australia. If you look into a bigger picture, if you look into USA, it's a very different system. If it comes to UK, Germany, Canada, Australia is bit better and more promising. So which means that the figure and the graph is coming more towards the Australian healthcare system, and now it divides the categories again, like how much experience you hold, what about the eligibility criteria. As Dr. Rizwan said, that silly questions, yes, we don't mind silly questions, but we need to have facts in our mind. You are asking for a job in Australia. Come on, like we want a competitive doctor to get into our system who can work in Australian healthcare system, and we want them to first use their common sense and understand the pattern and the background, and that's how we can assess them and we can take them. If I take 10 sessions or 20 sessions in a week, I know them where I need to put my more efforts and which person I just need to just give a push, and that can be sorted as well. So guidance is always matters, but we need to understand what is more important. I will quickly dividing my categories in a very short brief idea about the campaigns. We already know the campaigns is going on. It will be going till next year, February 2027, which means that we have a lot of time for the campaigns, and the shortlisting will be going. And surprisingly, this year I was able to see March, April, May, June, when the campaigns are not started even, that there are heaps of applications. For me, being a career counselor, and not only a career counselor, a passionate career counselor, I always get excited. I'm not one of those females who will be excited about shopping and filling my cart, but if I will see 20 jobs with RMOs, oh my God, I'm over the moon. You can ask my family about that as well. That, oh my God, there's so many jobs. And that makes me really passionate, and that's why I think it works. So I want you all to run that passion in a very strategic way as well. So if I talk about the first thing over here, there is no fixed slots for IMGs. You need to remember that. It's about the category we need to understand, and then we will move forward about that. Yes, we need to look into the job selections process. We need to look about the eligibility criteria, but for IMGs, you are always sitting there. You always got the slot over there, because if there is a local graduates, there is a categories, but they local graduates and everyone have their preference. Like let's suppose I belong from Karachi, Pakistan, and the recruitment is open for entire Pakistan. I only want to work in Karachi. I don't want it to work in Peshawar, Islamabad, Multan, because that's my preference. So which means that international medical graduate slots are always open there. So that's always, so there is no particular IMG slot, but you will find heaps of opportunities for IMGs. That's sorted. Second thing will be apply broadly. Make sure and remember one thing, and I still remember when I was having my mentorship by Dr. Rizwan, he said, Samra, you need to be open for everything, because first job is not your choice. The other rest of the jobs are your choice. And that you need to make up your mind. You need to open up. And I always talk to my students that I don't want it to know that what's the situation. Let's apply for that job. Let me take you to the interview stage. And once you get shortlisted, then I will bring this point whether you are going there or not. But right now, you need to be open for everything, and that's sorted, because you're looking for your first job, and that's not your choice. Unfortunately, but you need to apply broadly. If I talk about the second point, which I have noted, is about eligibility criteria. So now sometimes I always get a question, Dr. Simra, you say this job is only for those doctors who are eligible to, who are already registered in the system, but you asked us to apply. If I talk about working as a career counselor for almost 2.5 years with emergency focus, I got an idea about the hospital's preferences, about the hospital mood and behavior as well, like what they can consider, up to what extent they can go. If I talk about Keynes Hospital in Queensland, I will say if you don't have AMC2 or if you don't have that experience, okay, let's stop it. Don't invest a lot of energy over there. But yes, if you wanted to go to that hospital and that hospital might asking for those who are already registered, but why not you can just still apply? I think they do consider you and it happens. So eligibility criteria always matter. Yes, that is 100%, but you need to remember the hospitals as well, which you can see. And you don't need to know from anyone about the IMG friendly hospital. Yes, the mentors can guide you well about that. But there are a lot of groups, and I know you all are part of a lot of groups. You can even see 10 posts from one group that this hospital looking for interview for this hospital, looking for interview for that hospital. And that can actually help you guessing that. I still remember when I was preparing for my AMC exam and even for looking for the job market, I sit as an spy and I look for all the campaigns and all the groups, and I just write down the name of the hospitals that are shortlisting the candidates at that time. And I'm like, okay, something is going on in that hospital. Let's go and see what I can do to get me into that system. So that's how you need to be smart, and you need to know that yes, you don't have to apply for all the jobs that you're not meeting the criteria, but some hospitals still prefer, because I told you there is a category. Let's suppose I'm working in Sydney, Lima is working in Sydney as well, and there is a job for psychiatry registrar somewhere in Victoria. Lima and I even are not going to apply for that job because we don't want it to move from here. We wanted to stay here. And that's how we left that slot that is already reserved for us. And now automatically that slot is going to that candidate who are very experienced, but who is not registered. And that's how we need to use our common sense again. If we have that slot empty and if that hospital is IMG friendly, then you can go with that as well. The third thing I will apply and talk about is documentation. Dr. Rizwan has already spoken about that, and it's brief. It's a very detailed topic. I think I'm doing more than like 20 or 30. How many sessions I have done on documentation, and that's always a hot topic. Yes, if I talk about AI generations and all of those things about the documentation things, you need to be smart. And if I talk about my mentorships as well, if I have got 100 plus students, everyone has their own skill and strength. If let's suppose over here 290 candidates, I'm 100% sure my experience or Dr. Rizwan experience is completely different from your experience as well. So if what are you bringing, that is your skill and your strength, that should be different from me. So it does not matter if you are following a generic template, but how you are addressing and writing that thing, that is, you can go to Dr. Rizwan's YouTube as well. There are so many videos which I still watch
Mhm.
silently without telling him, to learn and understand what extra and what different I can do this time to make this thing worth it as well.
Okay,
So
Dr.
that
Simra, what
is
we'll do is we'll do Q&A quickly.
mm,
That'll
so
make our points more worthy of
yeah.
being specific. So just turn on your videos, guys, and be in a not an objectionable position or state of mind or state. Have some clothes on, present yourself decently, raise up your hand so we can pick you up, unmute you, and take the questions. Okay, and try keep it more generic. I won't be able to, and me and Simra won't be able to give a very specific, highly convoluted and complex career guidance. If you need that, that avenue is available. You can send us your CV. You can book in a career counsel meeting with myself or send in your CV. We've been doing that for a long time. All know emergencyfocus.net is the way to go. Now, apply for every job in every hospital and stop worrying about which are IMG friendly hospital. They're all IMG friendly. I've seen doctors getting their first job in Sydney, and I've also seen doctors getting their first job in somewhere in the regional. It's a free process. Don't disadvantage yourself. As Dr. Simra said, yes, she won't have a preference right now to work in Melbourne, but yes, she would have a preference. She did have a preference of applying broadly. So keep it broad. Your first job is the main task. So, Dr. Wajiha, please keep it short, sweet, and jump on it, please.
Hi, good afternoon, Dr. Rizwan.
Good
This is
afternoon.
Dr. Rajia here. I've been working like for 7 to 8 years as a general practitioner in the Middle East. I'm a graduate back from Pakistan. I just have a quick question that since I have not worked in a hospital setting in the ICU or ER here, but I do take in undifferentiated patients and emergencies. But usually the emergencies are referred to tertiary care hospital. It's a primary care facility here in Abu Dhabi, precisely in the
Yeah.
United Arab
Yeah, we got
Emirates. I've
it.
been working here for the last 7 years.
Yep.
Do you think I hold AMC one and
Mm-hmm.
I'm a permanent resident living outside Australia. So
Mm.
my question is, do I really need to take up a position here in the hospital, or if I'm going for a vacation back to my home country for 2 3 months, that is Islamabad? Do I need to do a rotation in emergency medicine in a tertiary care hospital to
Very
be
good.
competitive enough to get, a position
Very
in
good. Very
Australia at
good
the
question.
moment?
Thank you, Dr. Wajiha, for this question. I got your point. You're working as a GP for a long duration of time. Yes, you do
Yes.
refer patients to emergency department, but in order to apply for a hospital job, should you have a hospital experience back where you're working right now? Ideally, yes, but not. Uh, Look, I always believe that there are certain restrictions which are by default. So if you're applying for a hospital job and you get a hospital job in Abu Dhabi where you're working right now, fine. That solves every problem. We won't be having this conversation even. But because you can't, you can only rely on your GP experience. Now the point is, yes, use your GP experience, but highlight the aspects of that GP experience which would apply to a junior medical officer. You seeing the patients in terms of assessment, taking history, examining the patient, referring the patient to the tertiary care hospitals and specialists. Write that. As I said, it's more about matching that job description with being very reflective about it. So it does not disadvantage you. It's not biblical. It's not, there's no Bible or rule book like किसी ने foreign book खोल ली के, oh, let's open the rule number 285. She cannot apply. You can apply. You can get a job even. I've seen plenty of GPs getting a job. You even tick off the residency, you'll get a registration as well. So please don't disadvantage yourself, but give it your best shot. In that best shot, if you can spin off a hospital observation, hospital experience, fine. If not, go with the flow and keep applying and do AMC Clinical on top of that, because you can even get a very good chances of pesky. Next question, please, would be Dr. Preethu.
Yes, so this is Dr. Preetu. I'm actually working in India in Cloud9 Hospital with 2 years of pediatric experience and Royal College exams. So I'm actually planning to take my AMC Part 1 in this November. So my question is, what can I do CPD programs or anything to improve my CV? Like what courses are
Dr.
better for
Simra, would
this?
you like to answer that, please?
Hello, Dr. Preetu. For that, because you're meeting the criteria for recency of practice, so prioritization is your EMC one. So definitely you might be, if you're doing a bridging program for that, that can be a good one. Second thing is I do appreciate IMGs at least doing ALS advanced life support. That is one that is really appreciated as well. So that will be my second option. So I believe at this stage, ALS you can do to improve your chances of getting better with your professional development. And yes,
Dr.
prioritization
Prabhuram
should
would
be
be
your
the next one.
exam.
Dr. Prabhuram, please go ahead.
Thank
Good
you.
afternoon, Dr. Swan.
Good afternoon. Please go ahead and ask your question. We'll
Good
keep it
afternoon,
brief and
Dr.
very
Simran.
sharp and short.
Yeah,
Okay.
yeah. Actually, I'm a doctor from India. I have passed my MBBS in March 2021. From 2022, I have been working in hospitals. I have 2 years of experience in ED and 1 year in general surgery. But for the past 1 year, I worked in ships like offshore ships and cruise ship. Will they consider it as a clinical experience, or they will think it as a career gap and lack of recency? That's my
Okay, got it. So you're
thing.
working like, I
I
mean, I
already
get many
passed.
of, yeah, AMC MCQ,
Yeah,
is it? Yeah.
yeah. I already passed
Yeah, yeah.
AMC MCQ, but
Wonderful.
I am
Yeah. No, I
planning
got it.
to
I got
give
it. I got
the
it. I got it. So
yeah.
basically, look, I get many doctors who are working in a resort in Maldives, or sometimes, they're working on cruise ships. You're pretty much working like a GP. It's exactly the same
Yeah.
as the other situation was. So, um, try keep more specific, as I said, try keep relevant by matching those job descriptions. You have got a good experience in terms of emergency. which I'd be exploiting when it comes to shortlisting, which I'd be exploiting when it comes to interview. But if you're working in a ship right now, again, try to make that relevance in terms of assessing the patient, managing the patient, dealing with emergencies, retrieving the patients on shore when they're got like serious illnesses. So that is more important. And it's a your problem. It's your problem at the end of the day. Why do you spend time on ships? God knows why. Maybe it's good money, but all you could do is just try match it. We'll keep on
Yeah.
moving. All right.
Yeah.
And try to
Okay.
AMC
Thank you.
clinical.
Yeah, I'm trying. I also going to enroll in your complete job mentorship
Okay.
program.
Wonderful. Wonderful.
Yeah.
Dr.
Thank you.
Lorena. Okay, we'll move on. Dr. Lorena is not available, I think. Oh yeah.
Yes, sorry, I am here.
Okay, all right. Cool.
My phone was muted.
Okay,
So
that's
my
fine.
name is Lorena. I am from Colombia. I already on November passed the AMC clinical examination. I recently went to Colombia to close my gap in practice for I worked for around eight weeks. The thing is, I have over 11 years of experience in Colombia. So my question is there any position that I don't is do you recommend not to apply like a junior, for example, because I have lots of experience, or I can apply to any job?
Dr. Simra can answer this question. I think this is a very fair question and easy one.
Sorry, the video get cut, interrupted. So what experience in 11 years in Colombia?
I have at least 3 years of experience in emergency department, and the other part is mainly in a GP practice. In Colombia, we don't have a GP as a specialty, so that's why it's not valid here. So, yeah, it's
Sorry, it's just interrupting.
All
So
right. I
what
think,
I heard,
yeah. So basically, where is she gone? Dr.
Lorena.
Lorena. Dr. Lorena, your experience of 11 years, even if it's in a GP practice experience or more in a primary care setting, it's still relevant. Yes, if you can do the hospital experience top up, that is always going to be relevant. Top it off with the courses and acute courses, which are relevant to the courses like APLS and ACLS are must do, a must. So any of you who haven't done APLS and ACLS in the last 2 years, please do them. Clinical procedural skills course becoming a big one right now. So, the people who come and work with me in emergency department, if they can't, like the other day, there was a RMO who said, "Oh, Dr. Rizwan, I cannot put in a cannula." I said, "Oh, wow, it might be really hard because she's a very senior RMO." When I went there and had a look at the patient had, such big veins. Even blindfolded person can just palpate and put in a cannula. And this did not go well with her. Every consultant gave me the feedback about her, that she is not good at procedural skills. So do procedural skills courses, communication skills courses. Your GP experience is relevant and valid to apply for jobs. Now that you've got AMC Clinical, it's very good. All you need is a very polished CV with acute care courses and procedural skills courses, and you'll be on your way to get your first job here in Australia. Dr. Umme
Dr.
Hani. Yes,
Thank
Dr.
you.
Simra. Dr. Simra, you were saying something?
Yeah, sorry. I just wanted to add a very important point over here that what I have seen, because every year when IMG is getting shortlisted, the criteria of shortlisting has changed as well. So from last year of my experience, I can see that now the recruitments want persistence. So let's suppose if you are working in a GP practice or if you're working in pediatrics or emergency or ICU, so better is to keep working in that area rather than doing a shifting to something else, because that has been asked in interview many times as well. So if you have been working, and as Dr. Rizwan has said, like working in a GP practice, I have seen a lot of shortlisting in hospital setting as well, because you need to present that thing in your resume as a primary care unit where you have been exposed to the cases and you are doing the role of a JMO or an RMO duties while you are doing in a GP practice as well. So if you're able to do that, that would be great. So don't do frequent changes in roles as well. That is not appreciated in Australian healthcare setting as well. So that's, I just wanted to add.
Wonderful. Thank you.
Dr. Rizwan.
Yes, please go ahead.
I'm Dr. Mehani. I'm from Pakistan. I basically want to pursue my career as a general practitioner. Uh, I did uh, I did my MBBS in 2014, and after that, I did my MCPS and regional diploma in family medicine. So I would like to know. I'm currently working in a hospital setting in a tertiary care hospital, being equipped with BLS and ACLS. I wanted to know that if I want to come to Australia, the PEP pathway will be beneficial for me or the standard pathway?
All right. Okay. So this is a very important question. You're working as a GP. You want to come and work as a GP here. Whether the PEP pathway or standard pathway would be better. Any pathway works fine for you. If you've got an MRC GP, we would not even be having this conversation. You will already have 5 job offers lined for you. However, if you don't have MRC GP, do the MRC GP. If you don't want to do MRC GP, do AMC exam and come to the hospital medicine. Obviously, the same questions and issues will apply in terms of acute courses, hospital experiences, and making the CV, which is very relevant and reflective of the hospital experience. So at the end of the day, I would say one thing and make your life easy. It's job number one that matters. Whether it's in a hospital, whether it's in a GP clinic through PESCI pathway, whether it's through PEP pathway, that's what matters. How you want to get to job number one, it's entirely up to you. Whether you want to do MRC GP, yes, it's relevant, it's still active, still doctors are getting a job, so might be something that you'd like to consider with all that experience in GP practice. If you want to do AMC because you want a broader experience in hospital, which I think is a great idea, fine, do AMC MCQ and try to tick off those acute care experiences. And yeah, um, just go with the flow, but try keep up with a brave face on that one. Okay, next one is Dr. Sandhya.
Uh, good afternoon, Dr. Rizwan, Dr.
Good
Simra.
afternoon.
Thank you for this beautiful program that you're doing. I have got a job at John Hunter. I'll be moving there in August. Currently, my limited
Wonderful.
registration.
Congratulations.
Thank you, sir. I have a pediatrics master's with 3 years of experience in India. I want to know is, after working there, can I apply for specialist registration? And would I have to get all my logbooks and papers from India also, or can I start from scratch there, the referrals and the experiences?
So Dr. Sandhya, MD Pediatrics, want to apply for specialist pathway after spending some time in John Hunter. John Hunter is a good hospital. Now, a specialist pathway is very complex for general pediatrics. You need 3 years of basic pediatric training and 3 years of advanced pediatric training. You need to have an exposure to developmental pediatrics, behavioral pediatrics, child protection issues. It's a very complex application. I would like you to do a consultation with me first so I can really have a look at your CV and give you your realistic chances. And you may have a very good chance. And especially if you're working pediatrics John Hunter, that actually adds in the local references. In terms of documents, that's not a big deal. We can certainly assist you from that point of view in terms of logbooks. It's all template based, and we can make sure that you tick off all the boxes. But pediatric, I mean, I've done a video on that. It's on a YouTube channel as well, that what it takes is specifically for the pediatric specialist assessment. It is one of the toughest faculties of Royal Australian College of Physicians. And that's why I'd like to not give a blanket advice, but very specific advice. So 3 years of basic pediatric training. If you've got a senior resident experience, then 3 years of advanced pediatric training in general pediatrics, along with this development pediatrics, community and behavioral pediatrics, and child protection issues. If not, then the compensation will be coming from the consultant experience back home in India. So there's very few options that we can mix and match. We'll move on to Dr. J.
Thank you.
Thank you. And congratulations. Dr. J, yes.
Hello, Dr. Rizwan. It was a great presentation. So I'm from India and currently I'm third year ophthalmology resident. I'm planning on the AMC journey. So I just wanted to know that first of all, is a specialist pathway a reality that can be possible for me? And secondly, if I go for the AMC route, so this ophthalmology residency and further I'll be doing the SRship over here. So would that count as a recency of work or not?
No, and no, and no. Ophthalmology, definitely not. Okay, so do the AMC MCQ. You cannot come as a plastic surgeon, ophthalmologist. It's just too competitive. I mean, you're a third year resident. The training program here, have a look at that. It's like 5 years. People take on an average 5 years to get onto opthal training. So on an average, if a person here in Australia, which is an Australian medical graduate, is spending 10 years in ophthalmology, and after that doing an international fellowship in US, UK, or Canada, then you've got Buckley's chance to come on a specialist pathway with here 3 years of ophthalmology. So my well wishes for you. I think the best chance is to do AMC standard pathway and come and do a fellowship for your interest only. But try keep a very realistic spin on this one, because ophthalmology is one of those competitive and super competitive specialties as pediatric surgery, as neurosurgery, as plastic surgery, where the chances, if you've got very little experience, which you have, unfortunately, are next to nothing.
And would that the recency of work? So should I work in other departments for that?
how come your recency in Australia of even 10 years going to compensate for 3 years of MS ophthalmology back home in India when the training program here is more than 5 years?
No, what I meant was that for GP pathway, that is
Oh,
the
GP pathway. Then it's a completely different ball game. Yes, yes, definitely. If you come here, you have to get a full registration, you have to get a permanent residency, and then apply for GP training program. And that's a fair go. And I think that's a very realistic option for you. You learn better than ophthalmologist in more category if you are working as a GP. All right. All the best, Dr. J. Dr. Agalya.
Yes, hi, doctor. First of all, thank you for this wonderful session. I have an experience of 18 years, for 10 to 11 years in anesthesia and ICU, but currently I am in rheumatology. So it will reduce my chance for the DED or ICU related jobs,
Okay, let me
as I
answer
am
this
not
question.
currently.
I'll stop you here, doctor. No, nothing reduces your chances or nothing improve unless and until you're working as a doctor. You got any chance, you got every chance. So please don't ask these questions about if you're working in rheumatology, will it reduce your chance? You're working as a hospital doctor. Most of the hospital doctor jobs are exactly the same. You're involved in patient assessment, investigation, and management, discussing with the consultants, and you're a senior
No,
doctor.
actually, I mean that anesthesia ICU, not I am currently in anesthesia ICU. So is it okay if I apply for the anesthesia ICU related positions? That's why I'm
I think
asking.
apply for everything. As I said, apply for
Okay.
every little job, including a like emergency job, IC job, anesthesia job. Anesthesia job, you're not going to get an as AMG as a first job. Trust me on that one, because even Australians don't get anesthesia RMO job. They're only registrar jobs in anesthesia. On RMO, yes, rotational anesthesia you may get in second year. So apply for every job. Don't disadvantage yourself. And yes, that would be my advice. Don't discourage yourself. You got a pretty good CV, pretty good experience, and do your MC MCQ, and everything starts after you get your general registration. Dr.
Yeah, I have
Sumaya.
done AMC one. I have done AMC one.
Wonderful,
Thank you.
wonderful. Thank you. Dr. Sumaya, please go
Thank you.
ahead.
Good afternoon, Dr. Rizwan. My name is Sumaya. I'm currently working in Australia since past 3 years on limited registration. And I think I'm lucky enough I got in through WBA program for general registration. My question is regarding reference. Currently, I'm working in emergency medicine as a part of WBA program.
Yep.
I'm interested in anesthetics because my recent referees will be either emergency medicine or ICU. Should my past references are from anesthetics from India? Will emergency medicine referees counted for anesthesia jobs? Will it be
You'll be
helpful?
looking for an unaccredited job in anesthesia for foreseeable future. You can do what the best you can do. If you haven't got an Australian experience, which is an anesthesiologist, what can you do? You can put an emergency medicine experience, which is a very valid thing to say. And at the end of the day, references. Have you seen a reference report? I just did a reference this morning for someone. It's professionalism, communication, procedural skills. You don't need an aesthetic reference to be shortlisted for an aesthetic job. No, you need a reference to say that you're a good doctor, a good person, and a human. Okay. So it does not really matter. What you can provide is what you can provide. Just make sure that you provide which is the best reflection of your practice. And yes, your Indian references would be just as fine. And relevant. So provide 5, 2 from India, 3 from here, and see how you go. All right.
Thank you.
And then we go with Dr. Armin Kaktig.
Amazing. Thank you so much. Hi, I'm a medical doctor from Switzerland, and I worked 1 year in ED and plastic surgery back home in a university hospital. I'm in my last year of a PhD that I'm doing at UNSW, and I'm sitting AMC1 soon. My question is how helpful research experience is when applying, and if research counts as recent experience, or if I need to go back to
Okay.
Switzerland.
Yeah. You're barking up the wrong tree, Dr. Armin. You know that.
Okay.
All right.
Tell me.
So when you're applying for hospital job,
yes,
you need hospital experience. The
Okay.
research is your own thingy. And it's good that, look, it puts your CV out of in bit of a qualitative. And I think Dr. Simra would agree with me that when you've got 10 CVs and 3 CVs have got this good research experience, fine. But if you're applying for hospital job, employers are looking for, number one, a safe doctor. A research does not prove that you're a safe doctor. Now, you've got plenty of experience in ED and plastics, I would be harping on about it like a canary.
Mm.
I'm a safe doctor because I've worked in ED, I've worked in plastics. My assessment as a junior doctor did this, this, and that, all the pertinent points which are relevant to that job specific description. Your research obviously will help your CV stand out a little bit, but if you are gapping out for more than 12 months, that's going to create a problem for you.
Mm.
So try knock off a few weeks or months back in Switzerland and do the acute courses as I said to have a good chance. You speak very well, and I'm sure that you the first job that you get shortlisted with a bit of a experience in the hospital medicine, you'll immediately certainly get a job because
Okay.
Swiss hospital experiences are pretty similar, if not superior, to Australian job experiences.
Okay,
Or
amazing.
hospitals.
Thank you
Yes.
so much.
Dr.
Appreciate it.
Shifa, thank you, Dr. Shifa. We got 6 more minutes. Dr. Simra, is that okay? Yeah. All right, Dr. Shifa.
Thank you. Thank you, doctor, for giving me this chance to ask you a question. I have completed my MBBS back in 2015, and I've worked in ED for 2 years back home and 2 years for ENT. And then since I came to Australia, of course, I did a master's, and obviously that doesn't count. After that, I did public health officer role in the Victorian Department of Health for 3 years. And currently, I have just finished my AMC one. So I'm just, of course, the recency is needed, but what I want to know is what I can put in my CV apart from ALS and BLS that may stand out. And also, uh, I have been offered a medical administration job by one of the GPs. Would that help for the recency? Because I've seen in the APRA that there is non-medical recency criteria. So, like, I've
I'm not
done a
sure
bit
about
of
that.
research.
All right.
I've done a bit of research, but yeah, really, your golden words would.
Dr. Simra, would you like to
Thanks.
address that? I
Yeah.
have a
Yes. Hello, Dr. Shafra. First of all, I said that I don't think medical administration, yes, that it has, there are few things mentioned in that recency criteria, but when it comes to supervision, they're always looking for doctors who have worked as a doctor, and that can always make it like for recency of practice to be valid, it is only if you're working as a paid doctor. For you, the ideal opportunity will be, yes, that if you cannot go back to your country, if you have valid working rights, you can get into Monash MyPrep or NQ program that can not only give you observership experience, but they can also give you limited registration that can definitely cover your recency of practice gap as well and give you the registration for some time as well. I will not appreciate that you can shift to medical administration role at this stage wherever you're working in Department of Health. It's always a good experience to be shown in your resume as well. So I will rather advise you to prioritize your clinical and doing observership programs in Australia and looking for the opportunities, or you can go back for your residency. But if you have working rights, you have a lot of opportunities being in Australia, which can definitely cover your gap and to give you the opportunities to get into the system as well.
I would add
That's
one more thing that look, I'm not aware about that specific rule about having an administrative experience for a clinical job, but look, if it works for you, it works for you. Definitely do that. But I would certainly not feel very comfortable hiring someone who's been working in administration, who's been doing a master of public health, who's been working in administration capacity as an emergency medicine doctor. I just don't think it's
yeah.
a safe hire. So I think you need to give yourself a best possible chance. I know that you're taking significant efforts of returning back, and that's completely fair. And if you can do even 4 weeks of hospital medicine back home, then why not? Why not? Why disadvantage yourself?
Yes,
Okay.
doctor. Can I have one follow-up question, please? So this GP clinic also offers observership. Is it better if I just go for observership for maybe 6 weeks or so with the same GP? Would that count for hospital jobs?
Dr. Simra, what do you think about that? Observation?
I will say that rather than going for an observership, if you can work being in a medical administration and try to look for opportunities that can cover your recency of work practice, like looking for a paid, like for thing that can show you working as a doctor. And
Yes.
as Dr. Rizwan said, if you don't have enough of opportunities and you really wanted to take that observership, then the thing is that how you're going to present that experience in your resume and your CV, and how you're going to talk about that experience into your selection process in your application forms. So that really matters as well. It's your
And
decision,
yeah,
and you need to stand out for that.
I completely agree that, it's your problem. If you're not standing out on what are the requirements, essential requirements, it's your problem.
Yeah.
Me saying working in a GP practice or working in a master's or public health, it's not looking good. But that's just my assumption. It's your
Yeah.
problem if you haven't got the right tools to apply for the job, right skill set to apply for the job. At the end of the day, you need to
Yes.
ask yourself a question: why can you not do those painful decisions right now? Because obviously that improves everything for you. Otherwise, maybe things work out for you, maybe they don't. But if they don't, you know very specifically why they're not working out for you, at least.
Understood. Thank you.
Thank you. There was one doctor who has been waiting for a long time. In fact, everyone, Dr. Sumaya Habib. All right,
Hello.
I mean, I guess it's just getting a bit difficult to see all those. Just turn your camera on. We'll just go through 4 or 5 more questions. If you can turn your camera on,
Hello.
so it becomes easier. Yes, Dr. Sumaya, please go ahead.
Assalamu alaikum. I'm from Pakistan and I'm currently in Melbourne. I've got over 2 years of clinical experience and I'm actually a 17 times gold medalist. And by the time my AMC 1 result comes, most of the RMO campaigns would be over. And I'm going to start over observerships after that. So I just wanted your advice on what to do to improve my chances
Apply
of
for
getting
jobs
into
when you get your
America.
AMC clinical result, AMC MCQ result. Apply for jobs now. Just keep on applying for jobs. I think I've seen this question before. There's no restriction or you applying for a job. Does it cost? No. Does it limit you to apply for jobs? No. Keep applying for jobs. Say that you're pending an AMC MCQ result or whatever it is. And then if they shortlist you for an interview because you got 17 or 18 gold medals, that's fine. Don't disadvantage yourself. Please don't minimize yourself. That's the
So
biggest
shall
issue.
I
Apply for
start?
jobs. Yes.
Okay.
Yeah. Apply for
Thank you. Thank
jobs.
you so much.
Yeah. Good. All right. Now, next one, Dr. Vishal. And then after that, Dr. Akshita. Okay.
Hello, Dr. Rizwan. I am GMC registered doctor currently working in India. I have 2 years of teaching experience and I have 2 years of emergency medicine experience as a medical officer. And I was last clinically active in 2025. And I have done ALS from European Resuscitation Council. So should I switch to clinical as soon as possible?
Yes.
Or
Yes. Definitely. I think that's what we've been talking about for the last 1 hour. Definitely. Yes.
okay. And does the references count from India or do I have to take all the experience certificates from everywhere where I work?
I would not advise you to come to Australia just for ALS course. So wherever you can get the ALS course, you can do it from. It's fine.
No. Okay. Do I need the references or do I need the experience certificate from everywhere where I've worked?
No, you don't need any experience certificates for anything. You just need references. Dr.
Oh,
Akshita.
thank you.
It's mute. I'll see Dr. Musana. Dr. Musana, please.
Hi.
Yes. Hi, Dr. Musana.
Hi,
Please
Dr.
ask.
Rizwan and Dr. Simran. Thank you for the opportunity. Actually, I am an MG and currently working as a emergency medical officer in a 250-bedded multi-specialty hospital. And I have passed my MC1 and I have my MC Part 2 exam in August. And my question is, will doing an observership in Australia will add any benefit or increase my chances of getting a job?
I think, look, this is a very important question that, look, you're already working in a hospital setting, you're doing all the right things, you've got an AMC clinical exam. I think if you do the local observership and if you've got the chance of doing it, why not? People in the UK had been doing it with a good, successful outcome. And that's what I'm saying, that now we need to align our CV eventually to AMC clinical, the clinical observation, the acute courses, the more relevant clinical experience. That just condenses your timeline. Instead of waiting 18 months for a job, when you do all these things on top of what essentially is required, which is AMC MCQ anyway, then your chances are far better. And you're doing everything according to the book and even better. So well done to you. And if you got an opportunity to do the observation, definitely do that.
Okay.
Dr. Muhammad.
Hey, how are you doing? So I just wanted to say that I'm a doctor from Pakistan, and I'm also one of the PLAB refugees. So I did PLAB 1 and 2, and after that I did MRCP Part 1 and 2. Also recently did AMC 1. So what I wanted to ask was like, should I focus on completing my cases and then work, maybe join a specialty program, maybe, gain a bit of an experience working in hospitals in Pakistan, or should I focus my attention on AMC Clinical? But from what I've heard is that it's not really important. It doesn't really make a lot of sense for me as a person with POD.
Dr. Muhammad, I think thanks for your question. Look, I don't think that you've got much in a way of options. It's not, many options that you've got presented before yourself. All you can do is an effort and hope for the best. If you've done MRCP 1 and 2, I would definitely recommend complete the cycle and do MRCP paces, because obviously it is the membership exam. It does add value. It consolidates your clinical experience. So that's very good. When it comes to AMC Clinical, definitely improves your job chances. We've seen that play out countless time. AMC Clinical is king. Like, in addition to your clinical experience, passing AMC Clinical actually helps improve getting jobs for doctors who've got large career gaps. So both of these things are important, and you just need to prioritize it, which you can do early. If I were you, I would say do do your paces, because you've completed more than 2/3 of that, and then after that, focus on AMC Clinical and then Australian job market. Dr. Parth.
Hello, sir.
Hi, Dr. Parth. How are you?
Sir, I have been. I'm fine, sir. I've been working as a medical officer in. I'm from India, and I have been working as a medical officer since 8 months now. In a rural village. I have completed my MBBS last year, and I have recently given my AMC 1. So while in a village, I have been working as an in-charge medical officer of a primary health center, and it involves seeing around 70 to 100 patients a day. I have been managing any emergencies that have
Very
come.
good. Yeah.
I have been involved in various community health jobs, like vaccination campaigns and visiting patients at homes and motivating them for vaccinations and all. And I have been a part of the administrative work as well. So I wanted to know if this is a relevant experience that I'm taking, and should I continue here, or should I move to a tertiary hospital or some college to gain experience in ward-based work?
Dr. Parth, you have been
Also,
here for this session for how long now? Like this specific session?
sir, I actually am currently in
No,
a.
no, 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 no. I'm asking, how long have you been in this Zoom session for?
Sir, I just joined recently, like an hour ago.
Okay.
I'm really sorry, sir.
No, that's okay. We've covered this point. I'll share the video. You'll have this point addressed in detail. Continue doing what you're doing. Get the hospital jobs. Both of these things would be very relevant. And I think you'll have a good chance, because what you've described to me sounds very interesting. It personalizes your experience as a very good primary healthcare doctor. Doctors have been able to shortlist. Dr. Simra just said that, from primary care health experience. But if you are in India, you've gotten the benefit of getting into emergency medicine job. Why not? So it's about putting your best foot forward. Okay.
Okay, sir. Sir, and one more question.
Dr. Mubin.
Hello.
Yes, what is your question?
Sir, sorry. Then just the problem is that, sir, I'm currently working in a government hospital. So the references that I can get are, I mean, I don't have any references because I am not being supervised at this rural hospital. I am the in charge over here.
Yeah. I know.
And
You need to find a reference. It's your problem. If they need reference, you don't have reference, it's your problem. How do you solve this problem? You need to talk to some seniors. You need to work in a capacity where you can have some supervised practice, because at the end of the day, references are important. Nobody's going to take your word, how good your CV is, how well your interview, unless and until somebody vouches for you. If you haven't got reference, you need to find reference. Dr.
Okay,
Mubin.
Thank you, sir.
Assalamu alaikum and good afternoon to everyone, and thank you for this session. I have the query similar to Path. I am just way ahead than him. I have similar 3 years of experience in the public health places in the government, state government at India. So now I am confused about I should opt for the AMC 1 and AMC 2, or I should opt for AMC 1 and then PESK pathway. Thank you.
Just do the AMC 1 first and then come to that question later. I think that's more important right now for you. You need to start your journey at some point. And I think if you've not done AMC 1, I think any conversation right now by the time you've done AMC1 is going to be pointless. Market is shifting every month. Job is getting more competitive. Yes, you've got primary care experience. Pesky is a gold medal, you know. It's people get offered a pesky job and the boards doesn't give them registration. So who knows? I always say the best chance to start in Australia is a hospital doctor job. Very few people get lucky with pesky. Very few. Okay, so please do AMC MCQ. Focus on hospital job. There are thousands of jobs for hospital. If you compare that registration thousands versus pesky less than 50, it's cheek and jaws, man. Chalk and cheese. All right. I think that's about it, really. Dr. Divij Patel.
Hello, sir. Actually, I am a medical student right now in third year in India. So, is it like I have heard that we can give AMC Part 1 during our internship using the provisional medical certificate? So, like, is it possible and what should that document contain exactly?
Dr. Simra, what do you think? I'm a very passionate medical student from India from third year.
If she's asking about the AMC one can be given during internship?
Yes.
Yes, ma'am.
Which is at
Yes.
least
So
2 years away. Yes.
yeah, so I think for the documentation for AMC one, yes, I think for you need to make an account in AMC portal, and then you don't need internship experience for that. You just need your degree that needs to be very mandatory when you have to apply for AMC one. Apart from that, if you wanted to
They
know
don't
that
get
what
their
can
degrees after the internship.
Yes, ma'am.
before.
Degree is the question that we get after
Yeah.
internship
So
completion.
you can't really apply for
yeah,
AMC
you
MCQ till you
cannot.
intern. Yeah.
Yeah.
So you know that, right? You know that. You don't
But
get a degree before.
provisional degree certificate doesn't work. I have
Ask
like
APRA.
heard that.
Ask APRA. I think I don't know.
It
Yeah,
goes
I
to
don't think
APRA.
so
I'm not
because
sure
the
about
thing
it.
is Epic won't verify your degree with the provisional. So
Okay.
Epic will not entertain you. They'll say, honestly, give us a full actual thing. What is this provisional thingy? I know that you want to do that. Why not start preparing for it? And when it comes to that, complete your internship, do it properly.
Okay.
All
Thank
right.
you.
Okay. I think that's about it, really. Nobody else has got camera open. So I think people have had their issues addressed. Thank you very much for everyone who, Dr. Almitra, have we addressed your question, haven't we? No. Okay, fine. Lucky last.
Okay, thank you so much. Thank you. I'm from Pakistan, but currently residing in Rockhampton, and I'm not working for the since February 2025. I have two. My first question is while fulfilling the Queensland RMO campaign, there is an option, a column of hospital preferences. Would it be good to give preferences of Rockhampton, all 5 preferences with different departments, or do I need to give preferences of different regional hospitals like Gladstone or
Simra, what do you think?
Hello, doctor. I don't know about your experience, but what I can sense is you have worked last time in 2025, and that is 2026. That can take you probably to level 1 supervision at some stage because you might be only eligible for junior house officer positions. And for that, I will be highlighting that if you are going to Rockhampton for different preferences, you need to make sure that you have experience in those areas as well. Let's suppose if you wanted to apply for JHO in nephrology, cardiology, emergency, and medicine, so you need to stand out for that experience as well, and that's why you wanted to apply in those or slash your location preferences. But I believe the chances of being getting into those preferences can be minimum because I believe you should be open, and as we have discussed earlier, that should be your first job. So you need to be open because Gladstone is a very rural hospital and regional hospital. They might be looking for someone eligible for level 2 slash registrar positions that not making you qualify for that. So I will say not Rockhampton, but make it preferably for GHO positions and other IMG friendly network as well that can accept your credentials and what background you hold at this time.
Okay, thank you.
Pediatric experience. And one more question, sir. Just one more question. Does telehealth or online consultations, if we are doing, can fill the gap?
It will not fill the gap as make your recency of practice, but we have to remember that your recency of practice is still valid because it said 3 years, 3 months of experience in the last 3 years. So you can always vouch that despite you are overseas, but you have been working and gaining your knowledge to explain that you are doing something as your study plan during your gap, but that will not cover as your gap recency thing. But your recency is still valid, so I think you don't need to stress about this.
Thank you very much for that. Look, all of you, thank you for attending and asking your questions and being proactive throughout this session. Me and Dr. Simbra are humbled. Dr. Lima and Dr. Zara are humbled for you taking up the time and attending the session. Our AMC clinical course is starting next week. So if you want to register for it, the slots are open. Job mentorship program has been helping all of you. So please do consider enrolling in it. We're not going to make miracles happen, but certainly I can say that with our track record of getting hundreds of doctors to their destination and dream, we can certainly be a part of your journey. And it gives me an immense pleasure when I am a part of each one of your journey. And I feel Dr. Simbra feels the same way. So thank you very much again for joining. And I wish you all the very best. And I hope to work with all of you at some stage in your career very soon. Thank you very much. And Khuda Hafiz.